All of you know vesiculobullous disorders is a very important topic in dermatology, and we are going to cover all the important features like mucocutaneous manifestations, biopsy findings and DI findings in this video in a very quick way. Hello dear students, welcome to Crack Derma DrMSD, myself Dr. Maddineni Srinivas. So let us begin our discussion with the intraepidermal blistering disorders, which are pemphigus group of disorders, in which we have pemphigus vulgaris, which is the most common variety of this pemphigus group, pemphigus vegetans, pemphigus foliaceus and paraneoplastic pemphigus. So pemphigus vulgaris, remember, it is the most common type of the pemphigus, and in this there are going to be auto antibodies against both desmoglein 3 as well as desmoglein 1, and this is the reason why the patients are not only going to have the flaccid blisters and erosions over the skin, but also even the mucosa also can be affected in these patients. And if you do a biopsy, what are we going to see? Intraepidermal blister. And if you do a direct immunofluorescence, we are going to see the deposition of the IgG and C3 in a fishnet pattern intercellularly in the epidermis, because the desmosomes will help in connecting the keratinocytes with one another, and they are present everywhere in the epidermis. And pemphigus vegetans, the differentiating buzzword you need to remember is the involvement of the flexures is going to be there in these patients, and that too the lesions which you are going to see clinically are going to be appearing like cauliflower like blocks, most commonly in the axilla, and also they can be seen in the groin. Again, here also the antibodies can be desmoglein 3 and desmoglein 1, against which antibodies can be there, and fishnet pattern is also common. Next is pemphigus foliaceus. Here there is going to be one interesting thing. Instead of the vesicles and bullous lesions, these patients are going to have just scaling and crusting, which can be seen clinically, and the reason for this is because the anti-desmoglein 1 antibodies are going to affect only the superficial layers of the epidermis, that too which is involving the subcorneal level. So because of this, the roof of the blister which is going to be found is very thin, so that is the reason why we are going to see only scaling and crusting, and that too where are we going to see that? In the seborrheic areas. So this is first interesting point. The next interesting point is that this is the type of pemphigus in which mucosa is going to be completely normal. Why? Because they are only desmoglein 1 autoantibodies, but desmoglein 3 is completely spared. So mucosa is going to have the desmoglein 3 in higher concentration, so it is going to be absolutely normal because there is no pathogenesis in the mucosa. And again, it is going to be fishnet pattern, nothing different. Now coming to the last variety, it is paraneoplastic pemphigus. Remember dear students, this is associated with neoplasias. So in these patients, it was observed that there can be antibodies against various proteins, like for example not only desmoglein but also bullous pemphigoid 1 against antibodies can be seen, desmoplakin against antibodies can also be seen, and that is the reason why these patients are going to have very severe mucosal involvement. And recalcitrant mucosal lesions, if they are present in a patient, always consider the possibility of paraneoplastic pemphigus. Okay, so this is about the intraepidermal blisters disorder. So here we are going to see the next slide. It is regarding the subepidermal blistering disorder. So first one we are going to discuss is BP, that is bullous pemphigoid. In this, remember dear students, the antibodies are going to be against the bullous pemphigoid antigen 2 and bullous pemphigoid antigen 1. Basically these are hemidesmosomes, and remember here the lesions are going to be the tense blisters. So if you remember in the previous slide, whatever we have seen, we have discussed about the flaccid blisters. So there will be flaccid blisters, whereas here it is subepidermal, so the roof of the blister is going to be very thick. That is the reason why we are going to see the tense bullae in these subepidermal blister disorders, and that too especially remember bullous pemphigoid. Okay, next, what is the DI finding? Linear deposition of the IgG and C3. So IgG and C3 is common between pemphigus and bullous pemphigoid, but here it is going to be linear deposition along the derma-epidermal junction, or it is also called as the basement membrane zone. And remember, in this clinically the lesions are going to be tense bullae, and they can be present over the urticarial wheels, And if you do a biopsy, we are going to see the presence of eosinophilic infiltrate in the bullous pemphigoid. Next is EBA, epidermolysis bullosa acquisita. Remember dear students, don't confuse this with epidermolysis bullosa simplex, junctional and dystrophica. Remember, they are all genetic disorders. they are going to have the presence of the defect in the proteins of the skin, but there will not be antibodies in those conditions. Epidermolysis bullosa, simplex, junctional dystrophica, but here it is acquisita, so it is an acquired condition, so there are going to be antibodies. Again is the collagen 7, collagen number 7. If you remember, it is the anchoring fibrils, which is the other name for collagen 7, which is present in the dermoepidermal junction. And here what is going to be the deposition? It's going to be linear IgG and C3 deposition. So it is going to be similar to the bullous pemphigoid. How can you differentiate this from bullous pemphigoid? With the help of one special technique, you can remember, salt split technique. Okay, so that much if you can remember, that will be sufficient. Next is dermatitis herpetiformis. So here is going to be something very interesting. In these patients, the antibodies are going to be again is the transglutaminase. If you remember, this was a previous year question also, and this is going to be associated with gluten sensitive enteropathy, that is celiac disease or celiac sprue. And remember students, in this patients are going to have very itchy papillovesicular lesions presenting over the extensor surfaces. If we do a direct immunofluorescence, here is going to be something interesting. We are going to see the deposition of the IgA in a granular pattern along the dermal papilla and also dermoepidermal junction. So this is a DI finding. So in the biopsy, what are we going to see? Biopsy is going to reveal the presence of the subepidermal blister, no doubt, but we are also going to see the presence of the neutrophils. So neutrophils will be present in the papillary tips. So this is called as papillary tip microabscess, which is very classical of dermatitis herpetiformis. Remember, these are the important points. Next is linear IgA bullous dermatosis. In the children, this is also called as chronic bullous dermatosis of the childhood. Clinically, the buzzword you need to remember is string of pearls appearance or cluster of jewels, crown of jewels appearance, where annular lesions are going to be present, which will be having the periphery studded with small vesicles and bullous lesions. And here what is the basic problem? It is the BP120, BP2, BP1 antibodies against these proteins. And here we are going to see the linear deposition of the IgA. That is the reason why it is called as linear IgA disease along the basement membrane zone or dermoepidermal junction. Next is very interesting, Hailey-Hailey disease. Remember, dear students, this is a genetic disorder because of the mutation in the ATP2C1. If you remember, there is one more condition called as Darius disease, in which ATP2A2 is going to be mutated. So in this, basically what happens? Because of this mutation, there is going to be acantholysis happening, because calcium ATPase is going to be defective, and because desmosome requires the calcium ATPase activity, there is going to be a damage to the desmosome leading to the acantholysis. And remember, if you do a DIF, it's going to be negative, because in this condition there are no antibodies. And remember, dear students, there are other conditions also in which DIF can be negative. DIF will be negative in, we have already discussed, epidermolysis bullosa, simplex, junctional dystrophica, Hailey-Hailey disease, and also Darius disease. So remember, dear students, all these are conditions which are genetic, which are not having any autoimmunity. So direct immunofluorescence will be negative in these conditions. So quickly to summarize in the form of pictures, you can see this is the pemphigus DIF finding, in which you are able to see the fishnet or chicken wire pattern, very classical. And this is a picture of both bullous pemphigoid as well as linear IgA disease. So how can you differentiate? If I tell you that the deposit is IgG in a linear pattern around the dermoepidermal junction, it will be BP. If I tell you that it is IgA, it is linear IgA disease. And finally, we have the dermatitis herpetiformis, in which there is going to be granular deposition of the IgA along the papillary tips and also along the basement membrane zone. So I hope this video was helpful. If so, please do hit the like button, and also if you want more such videos on a regular basis, do subscribe and comment if you have any doubts. Thank you so much. Happy learning. Sarvam Sri Krishna from Sarvajana Sukhina Bhavantu.